Good afternoon, everyone, and welcome to our Urgent Protect Our Province COVID-19 briefing for Alberta. This unplanned broadcast is live streaming from the traditional and ancestral territory of many peoples. We are grateful to live and work in Alberta, a province on the traditional territory of 48 different First Nations and the unceded homeland of the Métis Nation. Today's conversation is being shared in ASL. This conversation for the public is also being shared live on YouTube, Twitter, and Facebook. Since we began these briefings, we have promised Albertans a regular panel of doctors and experts who endeavour to bring timely, accurate updates on the COVID-19 crisis in Alberta. And that is why we are here today. Thank you, everyone, for joining us. We're going to be looking at Alberta in depth today with some of the core members of our Alberta Protect Our Province team. This last week has been plagued by ongoing divisiveness, fatigue, and continuously increasing hospitalizations and capitulating rhetoric that has led many Albertans, I think, to scream into the silent void, asking, how can this be happening? And is there anything we can do about it? So that will sort of drive our conversation today, as well as what is happening in Alberta and its ties to COVID-19. As always, if you have any questions that you would like to put before the panel, please feel free to enter them into whatever streaming service you are joining us live on. I will start things off by bringing up Dr. Vipond to give us an update on COVID-19 in our province today. Dr. Vipond, welcome back.
So, we might as well just get right into it. We have a lot to talk about, and the numbers are only part of it. So let me just go to my thread, which I just posted. When we start with the cases per day, I always think it's important to have that caveat. The cases per day really don't mean anything now because we're restricting our PCR testing so massively that it's not really. I don't think it bears any relationship to what's happening on the ground. So. But for the record, it's 2537 yesterday. Positivity, which you see here on the graphic, is a better measure. And I just want to show how flat it's been for weeks now and continues to be flat. Yesterday was 34.49%, and last Wednesday was 34.96%. So essentially the same. Like it's trended down from 40 to 35%, but that's a very, very slow trend over time. So next graphic, you can see how high it is now compared to previous waves. It's really quite extraordinary. Next slide, please. So now we're getting into hospitalizations. As you've heard me say many, many times, because of recurrent revisions to the numbers, you cannot trust the numbers for the last 2 days. So probably the last real number we can trust is Monday, which was up 63 cases to 1529. It was initially reported on Tuesday as 1476. So you can see how big a change that is. It's been like a 50. And generally when I'm looking back over the revisions, sometimes the revisions from day of announcement to like when it's kind of generally finalized has been as big a difference as almost 100 cases. So, I mean, for example, yesterday, if you go by the numbers that were reported today, it would be minus 70, going from 1542 to 1472. And that's just not real. We just got to accept that it's not real. Next slide, please. And you can see on this slide that looks at the entire pandemic. This is ICU cases. Sorry. We'll go on to the ICU cases then. I got them backwards. ICU also continues to be extremely flat. Yesterday was +6 to 112. If you look at it, it's actually been since the 18th of June that we've been bouncing between like 114 for a high and 101 for a low. And now we're at 112. So you can just see we're just not going anywhere. And I think it's important to point this out in the context of both Dr. Hinshaw's Twitter account yesterday saying hospitalizations look like they're dropping, and also Premier Kenney saying we look like we've reached a peak. It doesn't look like a peak to me by the numbers. I can say that the rate of growth is slowing. I go back a few days to see what the 7-day change is, and it's been slowly dropping. So we are kind of peaking, but that doesn't mean we're essentially going to start to to drop, it means we're peaking. So, for example, when we're talking about this rate of rise, if we go Sunday to Sunday, it was a rate of rise of 14%, and then Saturday was 17%, and then Thursday I think was 20.4%. So that rate of growth is slowing, which is nice to see. Next slide, please. I always like to talk about the fact that there's kids still getting sick. I don't like to talk about, but I think it's important that we talk about it because it is something that's been minimized by our political leaders. So you can see that we have another 8 kids that have entered into the hospital, and one of those into the ICU. Next slide, please. And these are our deaths, really consistently being between 13 and 15%, 13 and 15 people per day being announced. And you can see that continues today. I've actually been pretty surprised. I thought, with Delta, we were seeing some younger numbers, and we are predominantly seeing people above the age of 50, still this sporadic younger person coming into the morgue, but generally it's a lot of older people. So if you just make that slide a little bigger so I can count, I think there's 11, if I'm not mistaken, 11 people over the age of 80. And yeah, I mean, next slide, please. I had the wonderful opportunity to go do some skating today on Ghost Lake, and looking at the beautiful vistas and the beautiful snow, and it just reminded me of why we stay and fight. Like this is my province. This is my mother's province. I acknowledge I'm a colonial immigrant, so I only have 2 generations here, but still I'm tied to this land, and I want to stay and fight to protect it and protect Albertans, and I just want to remind people, and was reminded today while I was off on my skate, that this place is special and that we need to fight. And so I'm just really happy that Protect Our Province Alberta exists so that we can continue to provide unbiased, unpolitical information to the public so that they can make good decisions. And I hope we're going to have an opportunity to talk about that today. So I'm going to hand it back over to Michelle, and we'll be going to our other guests.
Thank you so very much, Dr. Vipond. We will bring you back into the conversation shortly. As Dr. Vipond mentioned, our current hospitalizations continue to go up, and their continued rise is happening at a time when the government is considering lifting the restrictions exemption program. But what effect will that have, I guess, is one of my big questions in terms of not just all of our health and safety, but humans that are needing hospital care for COVID-19 and other things. And so that that bigger picture effect in Alberta on our acute care system, as we watch those numbers continue to rise. It seems every day getting higher and higher over any other wave in terms of folks who are requiring acute care beds, not to mention ongoing delays, diversions to everybody's access to what was once an exceptionally beautiful, robust healthcare system that continues to be under so much strain, is something that many days I think keeps me up at night. So I am very, very pleased to have Dr. Paul Parks with us, an emergency room physician, member of Protect Our Province from the Medicine Hat Regional Hospital, as well as the president of the section of emergency medicine of the AMA, to take us through a more in-depth look at Alberta's current acute care capacity. Thank you so very much, Dr. Parks, for being with us today.
Well, thanks for having us and let me kind of give a brief overview. I won't take up too much time because I want to be able to offer a discussion and questions. But, I think one of the big things that's difficult right now is that we keep hearing about numbers of hospitalized patients, COVID patients, and getting an idea of those growing numbers, and it being over 1,500 being a lot higher than the other wave. A couple things. It's as bad as it was in the 4th wave, but in a different way. Thankfully, we're not stretching our ICU capacity in the same way. So that helps in a lot of ways, because ICU, really sick people on vents in ICU need more resources, need very skilled care. And so we had to redeploy a lot. We had to cancel a ton of surgeries. We had to do a lot of measures that just to keep our system afloat in the fourth wave. We're doing similar with the fifth wave now in terms of just hospital capacity. We're struggling, putting people in non-traditional spaces, having to have staff deal with more patients, but not having stretched our ICU capacity the same way is a good thing, in that it's allowing us to cope. But like I said, it's just things are different. And the other thing that's hard is we hear just numbers of COVID admitted patients, but we kind of forget that we also have a lot of really sick non-COVID patients that we're seeing more and more that are very complex. A lot of them have had delayed or deferred care for over a year or more even, so their cases are more complex, and they still need to come into the hospitals as well. So I just have a couple quick slides to just give a picture. So if you can put up the first slide here. So this looks kind of busy. This is a snapshot from 31st of April that kind of talks about what our hospital capacity looks like in the province on the 31st. And this is where it gets confusing a bit if the minister, it's been the premier talking about, while the number of beds we have in the entire acute care system it's only 91% occupancy. That doesn't really paint the full picture, because if you go and look at the next slide for me, and this just zooms into what Calgary looks like, for example, and this is just, if you look, that number is on the 31st, there was 32 beds available in any hospital in all of the Calgary region and zone. Keep in mind, those aren't just for Calgary patients as well. I'm down in Medicine Hat. When someone's sick down in the South Zone here and needs really higher level of care, cardiac care like cath labs or stroke care or specialized surgeries, I have to send them to Calgary as well. But that 32, that number that you're looking at and all that wiggly waves and stuff, it's not, it's very difficult, because it's not real even in that at any given time, there's probably at least 32 patients sitting in our emerge departments that are either admitted or going to be admitted on that day. So in reality, we're over 100% of all the beds in the entire region are taken care of. And then the other thing that's not factored in, that's a major component that's different than whenever they're talking about historical capacity numbers from 2017 or 2015, or is that we're so understaffed. We're at historical levels of vacant, lines of nursing, and also vacancies from day to day because of illness, because of childcare, because of the million issues our healthcare workers are dealing with. And add the fact that we're in our fifth wave, and there's so much fatigue, and there's just morale is so low, and it's so hard that when we have a floor that normally would have, I'm just making up numbers as examples, but if they would normally have 8 nurses and they only have 4, and they put a fan out and try to call for extra nurses, there's no one to pick up and come in. And so those 4 are struggling with more patients and with less help. And so just that bed capacity overall number, it's very misleading. It's sure in the South Zone, we have some hospitals in Medicine Hat. Up in Fort Mac, they have some hospital beds while we're at our worst. But at the same time, Edmonton, Calgary, and Red Deer are actually functioning where most of their wards are 130, 140% capacity for their wards for COVID patients. So less staffing, more patients, and no give in the system. And then add on top of it infection control issues. So you can't just put any patient on a floor with other infected patients, and all of the issues around where patients can go, figuring out how to best protect all the patients, and how to deal with both patients that have infective symptoms and non-infective symptoms. So, while you're hearing messaging that the overall numbers across the province aren't too bad, I'm kind of reminded of the analogy of, just because the average depth of a lake is say 6 feet, it doesn't mean you can walk across it. It could be 1 or 2 feet deep for a good portion of it, but you're going to drown in the middle if you try to walk across it. And that's kind of what's happening now in our in our province is that, yeah, maybe it's only up to 5 feet or up to our necks in Medicine Hat and Lethbridge and Fort Maxey, but meanwhile it's a couple feet over everybody's head in Edmonton, Calgary, and Red Deer, and the hospitals are literally drowning because of their staffing and capacity issues. So I just wanted to give that little bit of a picture, because if you put the next slide, this is what's happening at the exact same time that the premier is signaling everything's fine. Is that Red Deer, as an example, is canceling all surgeries but life and limb, and this is on February 2nd. So this is like yesterday. I mean, so we're not making this up. Why are they doing it? They would never do this unless they have staffing issues. So it can be staffing from nurses to anesthetists, but also space issues, also infection control, and all of the million issues. It doesn't help for the premier to quote an average, what our average capacity is across the province, when you have some of our major centers are literally drowning. So I just, and I think in the end, the last thing I just want to say is that these stats they're not stats, they're people. Like if you're talking about 140% capacity on a ward, it means people are double, triple bunking in rooms made for only one person. People are in hallways, people are in closets and non-traditional spaces. I'm not making this up. That's what some of the big hospitals are dealing with. And I'll tell you, people are very frustrated and shocked when they see their loved ones are in these kind of scenarios, and routine kind of care like grooming and bathing and personal care that would be normally done at a standard level that's much better, is not getting done for days or weeks even sometimes, because the staff are so overworked, and it's a shock to patients and the families when they come into those environments. And it's a double shock when they've been watching the news and our Alberta health leaders are saying it's all fine, and yet we're not really hearing from Dr. Vernieu and some of the AHS leaders who would absolutely be able to paint the picture of what's going on. So, I just give the warning that, and as Joe just mentioned, maybe we're plateauing. That's awesome. Maybe the peak is getting up there and we're going to plateau and start coming down, but there's a lot of sick patients and a lot of care that we've got to get through in the next 4, 6, 8 weeks that, we're nowhere near through this pandemic right now. So I'll just hand it over to my fellow colleagues here to continue, and then of course we can have questions and discussion.
Thank you so very much, Dr. Parks. Next, I would like to welcome Dr. Gasparovich into the conversation. She's been a strong advocate for COVID elimination, a strategy that has worked in many jurisdictions across the globe, but one that has been demonized in Alberta by those with the authority who could consider prioritizing it, often with the premise of protecting our acute care system. And after listening to Dr. Parks, it is obvious to me that those same authorities have chosen to reject their original premise. Historically, we have loosened mitigation when a wave begins its descent, only to be hit again. So I'm left with will this time be any different? To share some information on what is happening globally and nationally, I am delighted to welcome back Dr. Gasparovich.
Hi, good afternoon. Thank you very much, Michelle. So I would like to talk a little bit about where are we now in Canada, with the pandemic, how the future will look like, and what we can do. That there is a way to stop it. There is a way to end it if we focus on stopping the transmission. So there's a little reality check at the beginning on the slide. So in Canada, we are in the highest COVID wave ever, which kills now more than 150 Canadians every day. So it kills as many people as it did during the second wave, when we didn't have vaccines yet. So we had very little in the second wave, just starting to have them. And now the level of deaths is even higher than then. Also, on the first graph, you can see that even now, with the wave declining in Canada, the level of daily cases is twice higher than it was in the highest point before. And also what is very concerning is that the rate of decline slowed down. And every time something like this was happening, it means that anytime soon we can be in upswing again. Next slide. So the important thing is that this pandemic will not end just by itself after Omicron wave, because one, the immunity both from infection and from vaccines wanes over time, so soon many people will be susceptible again. And two, COVID spreads in high numbers all over the world. So when virus replicates, it mutates and generates new variants. So basically, this graph shows of the number of mutations over time, and we can see that it was relatively stable, the rate of increase of mutations, but now with Omicron, it intensified, it sped up, and now we have reports that people who've been infected with Omicron, some of them already got reinfected with BA2 Omicron. So anytime some of those dots on the graph can shoot out another variant that will be more transmissible, even more immune evasive than Omicron, more deadly, or just transmitting faster. So basically, we will be all the time on the roller coaster of waves. Next slide, please. But there is a way out of it, and that's elimination strategy. So basically, by stopping transmission, we can get out of the pandemic. And here's the example. How does it work? Just the principles. Actually, that's illustration from Nova Scotia during the first year of the pandemic. They were very successful in using elimination strategy when they were using it. So first of all, with bundle of public health measures, and now also with vaccines and airborne precautions, we can stop the transmission. So we can drive cases down to stop all community transmission, to get cases to zero. And many jurisdictions achieved it over and over and over again. And once we are at zero, we can drop internal measures. So we can lift all internal measures, like, for example, we can open schools again in person, we can open theaters, we can gather together even in large numbers, because there is no COVID in community. So we are at zero risk then. But we have to keep measures that prevent reinfection of the region. And those are, one, preventing importation of cases from abroad or from other jurisdictions. And that can be done by a mixture, by combination of quarantine of incoming travelers, by vax passes and tests. And two, making the population in our region resilient to reinfection. So even if some cases from leaking from quarantine will appear, they won't lead to super fast outbreak, but to slow outbreak. And we can have this resilience to reinfection by vaccinations, by airborne precautions, and by aggressive testing. So, and then once there is multiple regions that eliminated COVID locally, they can form a bubble in which people can travel freely in a free way between those regions. And we have to be realistic. So occasional outbreaks from imported cases will appear. They always did in zero COVID regions, but they were stamped out with short enhanced local measures and brought to zero again. And what is important, so it was successful. Next slide, please. So Atlantic Canada was really successful in following elimination strategy. Till summer this year, all 4 provinces followed the strategy, and then 2 provinces moved to shift towards mitigation. So we can see that the colorful lines are daily new cases per capita, so it's adjusted per population, and colorful are in Atlantic Canada, and the gray one in 6 larger provinces that followed mitigation. So basically, Atlantic Canada focused on controlling transmission, and 6 large provinces focused on hospitalizations and deaths. And we can see that Atlantic Canada had dramatically less slower spread. They had occasional outbreaks that they stamped out, and which didn't leak because of quarantine. They didn't leak to other provinces, but they didn't have those dramatic destructive waves that we had. Next slide, please. And this graph shows hospitalization adjusted per population in Atlantic Canada, colorful lines, and in the 6 other provinces, gray lines. So elimination strategy provinces, that is Atlantic Canada, had much better health, economy, and mobility outcomes. They had much less deaths, dramatically less hospitalizations, and by this also less long COVID and less post-COVID complications. and better mobility, so better private individual freedoms there. Okay, and here also what is important, you can see that they had such small spread despite their neighbors, that is us and US, had uncontrolled transmission. So it is possible to be successful with elimination strategy with very little COVID, even though your neighbors have a lot of transmission. Next slide, please. And yeah, here is for the world. In the world, the regions, so New Zealand, Hong Kong, Taiwan, China, which followed elimination strategy, so which focused on stopping transmission, were and still are successful. They had and they still have minimal spread of COVID. Next slide, please. And they also have, they don't have mountains of deaths. They don't have mountains of hospitalizations, don't have mountains of non-COVID and post-COVID disabilities. So they have COVID under control. And so basically it shows that by example of these regions, we can see that elimination is possible and is sustainable as a strategy. And we can win with the pandemic too, but we have to focus on preventing transmission. So we have to really use all the tools we have to prevent transmission as much as possible. Even if we don't stop it completely, we will be in much better shape when like in the future than in comparison to what we are doing now. And we have tools. We have airborne transmission control, we have vaccines, we have isolation, we have test, trace, and isolation measures. So we have really, really a lot of tools that can be used, but they have to be used. And for example, airborne transmission control, we don't use it. So yeah, I just think that we should really prevent transmission as much as we can. Thank you.
Thank you very much, Dr. Gasparovich. As we move into our questions, I'm going to bring your fellow panelists back into the conversation. I know Dr. Vipond had some thoughts that he wanted to reflect on after listening to the two of you, and then I will move into media and public questions.
Yeah, I just wanted to kind of respond to both the presentations. Paul was mentioning that I had stated that the hospitalization growth was slowing, and so that was positive, and I want to acknowledge that. But it's important to recognize that those hospitalizations are a lagging indicator. And if you think of like hospitalizations as our best metric right now as what's going on the ground, policy is represented in those numbers. So the numbers and the slowing of the numbers is representative of the current policy that we have, and a little bit on the amount of immunization that's out there, and a little bit about how much natural infection there is. And I just want to reinforce that Omicron doesn't seem to provide a lot of natural immunity. So even though it's ripping through society and we're hoping that we're going to get this mythical herd immunity, it's probably not going to happen. So my fear is, and I think Goja, Dr. Gasparovich spoke to this, is that if we think of those hospitalizations as indicative of policy 2 weeks ago, that means that changes in policy today or tomorrow or Monday are going to change those hospitalizations in about 2 weeks. Think of it as a throttle on an LRT car. You push it forward, the things go up, you pull backwards, and it goes down. And so any change to the policy is also going to change the hospitalization. And unfortunately, the more we learn about immunity from Omicron, the more we see it's not there is no super immunity from infection.
Yeah, 100%. And plus, if we take the foot off of some of the public health measures right now, of course, we're just going to prolong the hospitalizations and that plateau for longer. That will have longer effects going on for the next 8 weeks or longer. Like, we don't know. Like, one of the things that is important to remember about beds too is it's not like someone's admitted to that hospital bed for a day and then 2 days later they're out and we have that bed for someone else. So when our hospital's at that high level of capacity and we keep adding more and more and more patients, that ends up, adding to the cycle and adds to substandard care and suboptimal outcomes, and people suffer for it needlessly. So I agree.
To start off the question and answer period of our discussion today, I would like to welcome Adam Toy from Global Calgary into our conversation with a couple of questions. Adam, feel free to address them to whomever or everyone. Thank you very much for joining us.
Yeah, thanks for answering some of my questions. Dr. Vipond touched on this a little bit, but I wonder if I might get thoughts from Dr. Parks about effects you anticipate seeing in the hospitals that you work in directly if/when public health restrictions are lifted.
Yeah, so I mean, the big quick answer is part of it is all about how signaling, how our leaders signal too. So if messaging is things are fine and we don't have to worry about restrictions, or the simple things like washing hands, masking, decreasing your contacts, and those simple things that are helping us while we're struggling, then signaling that people change behaviors based on that. Not that they're bad or they intend to do harm or get Omicron and cause troubles. It's just that they get this overall signal that the pandemic's fine, it's less of a risk, and some of those behaviors change. And so then, of course, we're at, like, I don't know how to say it other than some of the places are at breaking points. There's just no staff. They're so overworked and overcapacity and overcrowded in some of the big hospitals, that if you're asking us to keep adding X number of new patients to the hospitals every single day because the cases continue, it will hit a breaking point at some point. And like I said, I worry that that it's not just about COVID patients. It honestly isn't. It's that next heart attack or that next stroke, or the things that are very time sensitive, will get delayed. And there are cases of when the emerge departments are really late, really overcrowded, that chest pains are waiting 4, 5, 6 hours to get seen for time sensitive care. That kind of stuff trickles out. So that's what I worry about.
Adam, if I could just follow up on that with Dr. Parks. The messaging that's been coming from governments across the country, including Alberta, to this point through Omicron is Omicron is mild and everyone's going to get it. And I just want to take apart those two myths. So first of all, Omicron is mild. Well, right now we have the highest by far hospitalization rate that we've ever had in the pandemic. And we also have 15 deaths per day. So maybe it's relatively mild for the individual from a hospitalization and death perspective, but from a societal perspective, because of its high transmissibility, this is a devastating disease. The second thing I want to point out on that is that we don't know about the long-term impacts of Omicron. We know that previous variants have led to significant long COVID, somewhere around 20 to 30% for adults, somewhere around 2 to 10% for children. And we have no reason to believe that Omicron is going to be any better. It could even be worse. We don't know. And so we're really missing the long COVID aspect. If you had to roll a dice and 2 out of the 6 rolls would end up with you with a long-term disability, would you roll that dice? And so we really don't want everybody to get this. And so that leads to that second myth that everyone's going to get it. There's no reason why everybody needs to get it, especially if we have good public health policy, especially if we acknowledge airborne transmission. I go and see COVID positive patients daily in the emergency room. I have never gotten COVID. I don't plan on getting COVID, and it's because I know how to protect myself. And I think we're trying to teach Albertans how to protect themselves as well. So,
Dr. Gasparovich, did you want to add anything to that question?
Yes, so the COVID won't stop now with Omicron, and I would like to just basically repeat to what Dr. Vipond said, that because it's milder on individual level, because it transmits so fast, it kills much more people and harms much more people. And also it mutates very fast. We have new variants popping up much faster than previously. And we have already BA2 present in Canada. So we can get reinfected again, and quite often. And the question is now how many times one can take a reinfection on chest. So maybe today I'm okay when I'm getting infected, but can I get infected 10 more times within the next 3 years? Will I die eventually? And then also it's a question of equity, because some people can protect themselves better and some cannot protect themselves that much because they either work in the front line or are essential workers, so they are more exposed. So they will get the reinfection much more than people who can work from home. And also so there's equity of having sources, having money and resources and money, and there's equity of knowledge. And knowledge is not equally distributed. Me and my friends, we have access to data, we have access to knowledge, we know how to protect ourselves. But many people don't know that COVID is airborne and don't know that they should wear like N95 or N99 masks. And they don't wear them because they don't know how important it is. So they will get reinfected much more. And I think that's the duty of public health, to educate people and get this message as wide as possible so everybody can be protected. Thank you.
If I can just add real quick too, I'll just echo. So I've worked a bunch of shifts in the last little while, and I want to tell you that the word and term mild, we got to, I on almost every shift, every shift in the last 10 days, I've seen COVID positive patients in the emergency department. And I want to say that almost every shift, I actually have to explain that. I have to say that I know you're reading and hearing lots about this being mild, but it's a misnomer for them because they feel terrible. In fact, that's one of the reasons that they're in the emergency department is they feel really bad, even though their oxygen levels are not below 91%, even though they don't necessarily need to be hospitalized. I have to sit and chat with them and say, this is going to knock the heck out of you for the next 10, 12, 14 days or longer. And they feel terrible. So that idea, the mild piece is really just, it's a misnomer. It's just that, yes, thankfully we aren't putting, hundreds of patients into the ICUs, but the people that come into emergency they feel terrible. Sure, there's some lucky people out there that get mild cold symptoms, but and they emerge, they feel horrible, even if they can go home. And unfortunately, there's not a lot we can add to their care. It's kind of like, this is going to be rough for a while, and I'm sorry that you contacted us.
Adam, do you have a second question or a follow-up?
Second question in regards to some comments made by the Chief Medical Officer earlier today, talking about how COVID may become endemic post the Omicron wave and after hospitalizations fall. Just wondering what your thoughts are on this. I know that she's made comments about COVID becoming endemic, but I'm wondering what your thoughts are on that, especially given maybe some recent science as far as whether or not that'll even happen with COVID.
Yeah, so I will take this question. So endemicity has a very precise term in epidemiology, and it means that basically the disease will have R around 1. So it will be stable spread. So it won't grow exponentially, won't decrease exponentially, it will be just at 1. So for example, malaria is endemic in Africa. I don't think we want something like this also, but COVID has this exponential component in it. So it either grows up or goes down exponentially. I cannot see under what conditions it can become endemic and be under this the stable phase. And I didn't see anybody talking about endemicity who would provide a model showing under what conditions it will behave like this. So I don't think that it is possible that COVID will become endemic. We will be on waves most of the time. So yeah.
If I can do a quick follow-up on that. So flu has never achieved endemicity. It's seasonally pandemic, right? It seasonally goes up and down. There's never an R of 1. On the contrary, TB and malaria are both endemic. They tend to just float around in societies, not really ever achieving that exponential growth or exponential decline. And yet both TB and malaria, no one would argue that there shouldn't be severe efforts made to curtail their impacts, because they have huge impacts on the society where they're endemic. What I think when they use the term endemic, what they're really saying, and you'll hear this other term, is we need to learn to live with the virus. That's the other, you probably heard that talking point. And I would just counterpoint that by saying we really need to learn how to die with the virus. And as Dr. Gasparovich has previously pointed out, this is a very inequitable virus. It tends to kill the elderly, the infirm, the immunosuppressed, and some people just randomly. But the most vulnerable are those categories of people. And so what we're really saying is that we need the society needs to decide that our freedom to not wear a mask, our freedom to not be vaccinated, needs to take precedence over the safety of these people in our society. And I think for my training and for my set of values, and I hope that many Canadians share these values, is we should fight against that. We should be working hard to protect those that are more vulnerable.
Great. Thanks so much.
Thank you.
Dr. Gasparovich, you can add some more. Yeah, add.
On endemicity, so about flu being actually non-endemic, it's seasonal epidemic. And we are so lucky with the flu that it has R value just like a bit above 1, but not much above 1, enough that the change in the weather, so better season, summer season, can drop it down. So it goes down by itself, and it temporarily eliminates itself for a season until it comes back in the next season. But with COVID's R value is so high that it won't just go down by itself. And if flu had higher R value, R0, then, and if summer wouldn't save us from it, we would fight it like heck, because continuous spread of flu would be devastating. So we are just lucky with it that it goes down just by itself because of the season. But we have no chance for such an effect with COVID, with R0 or 6 or above. And also endemic, actually we have endemic diseases that got eliminated in Canada and have elimination status, which is rubella, measles, and polio. They are endemic in the world, but they are eliminated in Canada. So like all this endemicity narrative is very strange in this way, that we want something at high levels as endemic. So basically it's almost like pushing for having something akin to malaria in Africa.
Dr. Parks, did you have anything that you wanted to add?
No, they covered that definitely. So
excellent. Thank you very much for joining us, Adam. I am going to move into some of the questions that we've been getting from viewers at home. And then I wouldn't mind taking some time just checking in with all of you and how this number 5 has been feeling and sitting. We're getting a lot of questions around the cyclicalness. So with that sort of understanding and building off of Dr. Gasparovich's conversation around the fact that Omicron is continuing to divide, turn into different things, and will continue to exist unless we choose to truly suppress it and move it out of our environment. Have we observed in the previous waves like a cyclicality of it? So not even so much the seasonalness, but we have been going in those 2 to 3 month spacings. Is that entirely been due to public health measures, or does that have to do with the genetic makeup of the virus and how it's been changing?
So it's what we had. We didn't have here natural waves. So this waves with when you just run wildly the epidemic, it will go, it saturate, everybody who could get infected gets infected, and it goes down because it has nobody else to infect. Actually, what we had exponential growth that was crushed with public health measures. So anytime we put stronger public health measures, the wave went down. But then we opened too early, and we permitted the growth of new stuff. And the new waves were, after second wave, were always fueled by new variants. So first it was Alpha, that probably just with vaccines and small public health measures, the original variant we could stamp out, but we let the Alpha grow, and that we had the third wave. And then again, we crashed this wave with public health measures, but then we loosened the measures and then opened for summer and let the Delta grow and make new wave. And now it's basically unpredictable how big the next waves will be. We see the Omicron now and Omicron BA2. So I don't even know when this wave really will go down, whether it will be just small hump and BA2 will take over in a moment. That's what we can see in Denmark. Now they have BA2. So I think the cyclicality, it's not a natural cyclicality. So we cannot count on it that, okay, the next wave will be in July or June or something, that they can be much more dense, and even maybe we won't go down from the current wave.
Yeah, and the only thing I would just add real quick to that, sorry, Joe, is that while I was thinking of it, is that there's this narrative out there right now that's very misleading that the restrictions and public health measures haven't worked, which is crazy because they have. So, but it's very there's tons of evidence that the public health measures and things like masking and vaccines and even restricting social access and congregation, that works. So I want to be very clear to people that they do work, but if we do them in a half-hearted measure, or we take them off where or there's issues where you can go to big hockey games but you can't go to restaurants or things like that. We've applied them in various ways, but I just want to strongly say there's no question public health measures work and they've saved lives and they've been helpful. It's just that I just don't want the discussion as people are talking about lifting the rep and the government's looking at some of these harsh and rash decisions. I don't want people to be confused and think that there's debate that the public health measures don't work.
And I guess I'm just going to riff on all of this and say that, man, we are so darn tired of these waves, right? Like, this is so hard. It's a roller coaster, and it's literally a roller coaster. It's, oh my God, we're going up, and oh, we're going down. Oh, thank God we're going down. And oh my gosh, it's over. And our public health officials like, this is it. You guys have made it. We got the vaccines. It's over. And then, oh my God, we're going up again. And this is, how many times have we gone through this? And I can understand the frustration that I hear in people's voices or on Twitter about these waves and how, like, you told us we were done and now we're not done. And then you told us that all we needed to do is get double vaccinated. Now you're telling us we need to be triple vaccinated. Like, why is this happening? And unfortunately, this is relatively predictable. This is predictable because of variants. And this is predictable because we still haven't gone those extra couple measures in order to try and get it down far enough. And the problem is that when you get such a level of fatigue and frustration, there's this, well, that's it, I give up. I might as well get it, right? Like, bring it on, because I'll get it. But then, as I mentioned earlier, we've been sold a lie that if we get it, then we're done, right? Like, we're seeing people that are getting it and then getting it again. So what we really need to do is be honest with the public. We need to deal with reality, even though it's a shitty reality. And that means that we need to suppress when we're in the midst of a heavy wave. And when we can, we should be interacting in as safe a measure as possible until such time as we truly see the end. And so I still see friends. I go on lots of walking meetings, and I do lots of exercise outside. I really focus on being outside. When I'm indoors with people, I wear a respirator mask. And, it's not perfect, but it's also not impossible. And I think this idea that unless I can have my life in March of 2020 or February of 2020 back perfectly, then it's a failure. I don't think it's going to serve us well. We need to deal with the reality. Our leaders and our public health leaders need to communicate that reality so that we don't keep feeling like Lucy, Charlie Brown with Lucy in the football, being given the golden glove and then having it taken away, the golden ring.
And the all or none feature is crazy too. The whole discussion of getting rid of the rep now, it's going to be misleading, and they're going to all of a sudden forget that, putting HEPA filters in our schools and doing other things could make a massive difference. This whole all or none cycle is crazy, and it's part of what's contributing to it too. Sorry, but I just it's should never be a discussion about all or none. It's like, oh, well, we'll just take everything away and give up. That's crazy.
Yes, and we could just end it or get ourselves into much better place if the leaders had a clear goal, communicate the clear goal to everybody, but not misleading, not saying that the vaccines alone will take us out of it, because it was clear in December 2020 that vaccines alone won't take us out alone, because from math of it that was impossible. And once we had variants, it was totally obvious that it's impossible. It was totally obvious that we cannot protect children only by vaccinating the adults. We would need to vaccinate more than 100% of adults to do that. But this message was propagated and communicated to people like this. Well,
until we have a sterilizing vaccine, which is still a hope, right? Like that's got to be the quote unquote golden ring, is a sterilizing vaccine. But until we have that sterilizing vaccine, we need to do
once we have this
Vaccine Plus.
Mm-hmm. Totally. But Vaccine Plus, in some moment, we didn't need to add very much to vaccines to really stop all transmission. And it's this physical thing. Like if you have mice in your cellar, you need to kill all of them. You don't leave like two couples and then say like, okay, I'm good. And oh my God, again, my cellar is full of mice. How did it happen? Yeah, it's biology. If you leave a little bit of something that can grow exponentially, it will grow exponentially. You just need to kill it completely. And I don't know how we lost the concept of zero, like that materially, if you have zero something, you cannot multiply it. Anything multiplied by zero is zero. So you can grow and it worked. It worked everywhere. Like stopping transmission worked wherever it was used as a policy. And interestingly, in Canada or in Alberta, it wasn't on the menu. We never had open, honest discussion about our strategies here. So it is very strange, and still I don't understand, and I don't understand that.
And one thing I just add quick to that too, that has to change quickly, if not sooner and then later, is that we don't actually know what our public health advisors were ever advising our government. We have no idea what the Chief Medical Officer of Health has been telling the government as to what the best public health measures are for our society and for safety. All we know is the effects of what the government's decided. Same thing's happening right now. If there's all this discussion about removing the rep, we don't know what Dr. Henshaw and the public health experts are advising our government. We're only going to find out what the government decides to do. And that's a failing. That's a problem. When you're talking about major public health measures that affect everybody in society, we absolutely need transparency to know what the experts are advising and have it unfiltered before the political process occurs.
If the restrictions exemption program gets dropped next week or changed in some fashion, what do you guys feel that is likely to do to this current wave? Will Omicron, I mean, I can't even figure out exactly how we judge how much is currently in the community with the lack of testing, but what do you guys think we will see happening?
Can I start? Because I just did an interview with this on City TV, so I've been thinking a little bit about this. So the restrictions and exemptions program, let's be clear, it's a vaccine passport. So they're using this Orwellian language in order to hide the fact that it's a vaccine passport. So let's call it a spade a spade. So it's done three things. It's decreased transmission rates, because we know restaurants are sources of transmission and other public spaces. It's increased the amount of vaccine uptake, because people have immediately following the announcement that we had an increase of that. And the third thing it's done is, I'm going to forget now. There's three things that it's done. How embarrassing. Decreased transmission. I'm gonna forget. I'll come back to it. But anyways, so right now, I think let's be honest and say that 2 vaccines do not substantially decrease transmission rates from person to person. And that is being correctly said by a lot of politicians, including our public health officer and our premier. So that is true. But we shouldn't just stop there, right? So if it's not working well, do you scrap it or do you make it better? So I'll use an analogy. In the 1950s and 60s, we had lap belts, right? Do you remember the seatbelts in the old Ford Mustangs that just went across the lap? And they weren't very good from an emergency doctor's perspective. You know, people would do these hyperflexions, break all the bones in their back and have hit their head against the steering wheel. So they weren't very effective. But instead of saying, well, that's not working, let's get rid of the lap belts, we actually just added a shoulder belt to it too, right? And now we have these shoulder lap belts, which are remarkably effective. And I think there's probably umpteen examples of this in engineering where something really hasn't worked up to snuff. And so we've just adapted it. So instead of scrapping the vaccine passport, what we really should do is be increasing its stringency so that 3 vaccines are within there. And so what that's going to do is it's going to increase uptake of that booster, which we know we're under providing right now, or the uptake is less than we want, and it's going to decrease transmission. And whatever that third thing is, I forgot to, I can't remember right now. But anyways, that's my thought. Now, I don't think that this government has the political gumption to actually to go that direction, but I think that's what should be done, and I think that's what we should be talking about as the public.
Yeah, I don't know if it was one of your points, but there's no question a vaccine passport still signals to people that it's a big risk out there still, and that it's that mindfulness about the fact that it's a risk, and the mindfulness and reminder of doing the other precautions. So I don't know if that was one of them, but it's definitely a benefit.
I remember what the third one is now. It's actually made our restaurant system safer. And so that I think that there are more people willing to go into restaurants. And I fear that in this day and age, I had to choose between scrapping it or adding a third vaccine. I think scrapping it will make the learned amongst the population less likely to go into a restaurant. Whereas if they improve the stringency, it would make the restaurant industry more resilient. I knew I would get it. Thank you, Paul. You triggered it. I don't know how, but you did.
Dr. Gasparovich, do you have anything to add on what will likely happen epidemiologically in terms of spread if we are to remove our vaccine passport?
So when we remove any layer, the cases start either slow down less or just go up. But usually we don't see it immediately, but after 1 week or 2 weeks. And also what Dr. Park said, exactly that if it's a signal for people, if we remove measures, it's a signal for people that all is over, all is good, and people start to behave less cautious on other level or on other things as well. So that includes, then it increases the spread. And on the other hand, like every time we've been reaching the top of the wave, or we've been going up with the wave 2, wave 3, and wave 4, because doctors were warning and saying that, raising alarm that it's really, really bad, people started to behave more cautious and make a kind of like voluntary shutdown. And even before the most stringent measures were announced, wave already started to bend down. So it's always the psychological part of it. And I'm afraid with the removing of restriction exception program, that that it is first step, and then we will remove mask mandates and remove something else and something else, and especially removing this non-invasive things, because vaccines are not very invasive, they don't interfere with everyday life, then the spread will be higher, and then we will need, again, much stronger invasive measures to counteract it.
We are at our sort of towards the end, but I do want to take another couple of quick questions and then leave you guys some moments to just share some overall thoughts of the last few weeks, especially as we get closer to the weekend with ridiculously high hospitalizations, an unsustainable amount of daily death, and the potential of some of those layers of protection being removed. We're getting a lot of questions around the cultivation of new variants and whether or not, when that happens, as community transmission continues and the virus begins to change and adapt, whether or not we are, is there a way to predict whether or not the next variants will be less deadly, more contagious, less contagious? So sort of that, yeah, any thoughts that you have on that, or is it just at all a big unknown?
So the new variant will be more transmissible, so it will have transmissive advantage, because if it transmits faster, it wins. So it can be more vaccine evasive, immune evasive, or have more higher intrinsic transmissibility. But whether it will be more deadly or less deadly, we don't know, because the evolutionary pressure doesn't work there at all. Like, because this virus transmits very often asymptomatically so I can transmit it before I develop symptoms. So in a way, the virus doesn't care what happens to me after it's transmitted, unless we reach the level where half of the population is dead and so on. And because of this, the virus doesn't have any more hosts, but we don't want to get there. But in this short time span, it doesn't care if it doesn't harm the virus to be more deadly to us. So it can happen.
The one caveat to that may be that when a mutation occurs to make that virus more transmissible, it may actually make the virus less deadly, but may not. As Dr. Gasparovich says, it's not clear, but like it's not driven by that transmissibility. But sometimes in evolution, if you advantage one thing, then you disadvantage another. So we'll have to see what happens along those lines. I hope that makes sense.
Since we have two ER docs with us today, a question that we've received in the past and something that I think we will do a future briefing on, if I were to contract COVID, maybe even to the point that I needed to come visit either of you in hospital, but I wasn't at admissions point, so you were sending me home, what should I do to help myself heal? What should I be taking medication-wise? What should I be monitoring? That sort of stuff as people sort of prepare their at-home care kits as we continue to move through this highly transmissible way.
I could go real quick because I say it every single day. You know, simplifying it in the easy, simple terms. A couple things are essentially how hard it is to breathe and how staying hydrated. So the two big reasons that we have to admit people to the hospital mostly are around how hard their breathing is and or their oxygen levels. And the other is, especially too, with the previous variants where they lost a lot of their smell, taste, and this variant now has diarrhea and nausea and vomiting. And so getting dehydrated, not being able to stay very hydrated, that then just compounds things. So what you can do at home is isolate. Tylenol, Advil for that the aches, the pain, lots and lots of fluids. Try to force yourself to eat a little bit and lots of rest. And you know, honestly, it's like, for the most part, if you're able to stay at home, it's like, what would your mom do for you? Get the chicken noodle soup, get the fluids, get Tylenol, Advil, and rest. And that's for, you know, the people that don't need to come to hospital. The warning signs in the simplest terms of, I tell people, if you are finding where when you're sitting doing nothing at all and you're struggling to catch your breath and you're breathing really fast or you're really feeling short of breath, that's one of the signs you should come see us so we can check you out. And then the other is lots of vomiting, diarrhea, really dehydrated, really weak. And then, of course, just weird things like lots of chest pains or things that are different. But for the most part, especially loved ones, I tell family too, what you watch for is going to be how well they're staying hydrated, but then how hard they're working to breathe. So if they are sitting there doing nothing at all, and you see that they're still struggling and working hard to breathe, that's when you need to see us.
And I'll just add to that, there are 2 outpatient therapies that are being delivered by AHS. One's a new oral antiviral called Paxlovid, and the other one is an IV monoclonal antibody called sotrovimab, and they are both effective for Omicron. There's very specific criteria that we use in order to decide who can get that. You have to have a positive PCR, I think, is the first thing. And then you have to have either age criteria and being unvaccinated, or some type of immunosuppression in order to get those. For the general population, there's still 2 repurposed outpatient medications that we can use. One's an inhaler called budesonide. It's an inhaled steroid. And the other one's, interesting enough, an antidepressant called fluvoxamine. The evidence for both of those isn't great, but they're relatively cheap with relatively low side effects, and can be given at home without the help of an AHS staffer. So those are other options, and they've been shown to in a small number of people decrease the risk of hospitalization and maybe decrease the duration of the symptoms. So talk to your doctor.
Yeah, talk to your doc if you can. Talk to your family doc, because they can add that. And Joe's exactly right for those patients. I want to really stress this again. When I see patients in the emerge that are well enough that can still go home, they still feel terrible. Like they really, it's not mild when they have to come into emerge to see me to be told, well, thankfully your oxygen's good and your hydration's good and you get to go home. You're still going to feel terrible. So do these things like fluids and Tylenol, Advil, but we do add those meds too. When like the inhaler and sometimes the antidepressant, we'll add those to try to help those patients that are not sick enough to come in, but felt really, really bad and had to come to emerge and get checked. And the only other thing I'll say out there for patients now, 811 is very confusing, and the whole discussion around getting a PCR, I'll just tell you that if you're not really sick, don't go to the emerge to get tested, because that's not an option anymore. So we're just testing the really sick people. So I just want to save people a lot of that frustration and trips when they're trying to find PCR testing because of work reasons or other things like that. It's a very problematic problem it's tough for people out there that when they can't get rapid testing and can't get access to PCR.
Is there potential as supply increases for the antiviral medications to help us turn some of the tide in terms of earlier, easier access, preventing hospitalizations?
Hard to say that.
Go ahead, Paul.
The biggest thing right now is it's still restricted, limited. So they're still restricted to the criteria that Joe was saying, mainly our non-vaccinated people, or aged, very elderly, and or lots of comorbidities and lots of illnesses on top of it. The orals are still restricted at this point to those people. So the first thing I would just say is, it's a little bit insane for people to not get vaccinated and avoid getting ill at all to rely on a pill for once they're sick. So don't do that. So get vaccinated if you're not. And then like Joe was saying, that if you have lots of comorbidities or you're over 55, then it's worth talking to a doctor, because maybe it could be released, but it's still limited release.
Yeah, I don't actually know. So I think it's important to be able to say, I don't know what's going to happen as supply ramps up. We'll get more scientific studies out there. Maybe there is more information out there that I just haven't read up on. And maybe there's some future world where we have a pill in our pocket, and when we start to get a runny nose, we pop it down and deal with COVID that way. But we're not there yet.
But and also, I agree fully. And I just say too, keep in mind, we use funny terminology in medicine. So mild meaning you don't need to be hospitalized. Same thing. Those medications mostly prove that you don't need to get hospitalized, and it decreases your severe outcomes and hospitalization and some of those markers. And in fact, there can be expensive treatments. And so the reason government are paying for them is because it stops expensive hospitalizations. But it doesn't necessarily mean that you go from you're only going to have 1 day of symptoms and you're not going to have any long-term effects and you're going to be you'll be fine in a day or two and poof, you're better. It doesn't mean that. And so be cautious. I really strongly say be cautious. It's not a magic pill that, oh, don't worry, I can get COVID and I'll just take the pill and everything's groovy. That's not what they're doing for us.
As we get ready to say goodbye, I would love to offer you each of the opportunity to share any remaining thoughts that you have. Maybe we'll keep going with Dr. Parks and then over to Dr. Vipond and then finish off with Dr. Gasparovich.
Yeah, I mean, I think I'll just say, I've been saying it a lot, but the healthcare workers, we're in this with everybody. We're tired, fatigue's high, morale's low. Just speaking on behalf of all my allied healthcare professionals, the nurses and respiratory therapists, and just they're worn out. So be patient with the ones that do show up. And we get 8-hour, 9-hour waits in emergency departments. Suck. We don't want that. Nobody wants that. But the triage nurse that's out there trying to see who's the next sickest to come in isn't doing it on purpose either. So just I guess the last thing I'd say is I was very intentionally put my Calvin and Hobbes hugging each other in the background, because I can tell you, I think the world needs a bit more kindness and hugs and and good thoughts, and being kind to healthcare workers right now. They're worn out. So that's kind of the message I would send.
Virtual hug to you, Paul. Yeah, I mean, I think if we can veer off the medical aspect of things and talk a little bit more about society. I've been really disturbed by what's been going on in Ottawa and on the border with the United States. I feel that if it's true that the government has negotiated a deal with the occupiers of the border, that this does not bode well for our democracy. There's a reason why generally people don't pay ransoms to terrorists. And the reason is that once it's been proven to work, it tends to be used again. And so now that this new technique for changing policy has been adopted, what's to keep other attempts to change policy through this mechanism? I fear that it could be co-opted. And I speak this as somebody who has protested downtown with Dr. Gasparovich and with Michelle, but so I'm a bit conflicted, because I do think that there is a role for freedom of expression, for protest. But I'll just point out some of the differences. Like we were always calm. We were always engaged with the police. We stuck to public territory, terrain on either on the sidewalks of Calgary or the McDougall Center. And as soon as we had that test, trace, and isolate reversed, we packed up and we went home. And so I do think there are differences. I think we could probably have a debate as to these techniques, but I feel that blocking a major highway until you get your way, and getting your way is a very dangerous precedent for our society. So yeah, I worry. I'm going to be up at night tonight thinking about that.
Yeah, I think we didn't blackmail anybody. That's the main difference. Because we've been protesting, saying what we want, but we didn't blockade anything and we didn't blackmail. So, so I would like to say that if we can care about each other and avoid getting infected and ask our governments to stop the transmission and end the pandemic, and then let's learn to keep COVID at bay, basically.
Thank you all so very much for joining us. It was great to be able to have time to have this conversation with the three of you. Thank you so very much. With this internal feeling of ongoing governmental abandonment and the lack of fatalism that we like to promote in terms of avoiding Omicron, I would just like to take this moment to remind everybody not to shovel snow naked. We've talked about it before, that it is not which layer you choose, it is how many you use. And as we continue to go through potential changes to what mitigation measures remain in place, please try to keep yourself and those you care about safe. I guess building off of what Dr. Gasparovich just said, a call to action for the weekend that started last night was the hashtag REP, not RIP, or RIP, depending on which way you want to view it, based on the letter RIP combined with the mortality rate. We need to keep the protections currently in place to minimize the damage to our communities and to those we love. So if you are a social media user, please consider downloading this image that will appear on our website around 6 p.m. today and replace your profile picture with it for the weekend or longer. Oh, yeah, that's one too. Thanks, Jeff. We know that now is not the moment to be taking to the streets. It is still not safe for those large-scale gatherings, and rallying peacefully in person is not in the cards currently. But digitally, we still can take steps to be heard before more irreparable damage is done. So if you are so inclined, around 6 p.m. today, visit www.popab.ca and download the image, change it, share it, all those wonderful things. We will be back again next week. As always, stay safe, Alberta. Remember, COVID-19 is airborne. Wear the best mask or respirator with the securest fit you have access to, and vaccines are still saving lives. Thanks again for joining us.